and we'll get started in just 1 minute. Good afternoon, and welcome to MHPA's Webinar Wednesday series. My name is Patrick Core, and I'm MHPA's Director of Membership and Partnership Engagement. I'd like to take a moment and provide a brief introduction for today's webinar. Today's presentation is in listen-only mode. If you have any questions throughout the webinar, just click on that Q&A button located at the bottom of your screen. We welcome and encourage any questions at any time, so please do take advantage. Our presenter will address questions at the end of the presentation. You'll also find recording of the webinar on MHPA's YouTube channel, so that'll be available for you. You can share that with your colleagues. I would like to welcome and thank Brian Peltz from Tabula Rasa Healthcare. Thank you, MHPA Bronze Partner TRHC, for presenting today's webinar, Reducing Total Cost of Care Through Innovations in Medication Risk Reduction, a case study. Preventable adverse drug events result in billions of unnecessary health expenditures annually. Traditional one-to-one drug analysis can miss potential medication risks posed by polypharmacy. Combined with MTM programs, TRHC's unique MedWise technology addresses the growing number of states requiring pharmacists to provide services to their Medicaid populations. MedWise helps pharmacists identify, prevent, and mitigate adverse drug events through its simultaneous multi-drug analysis. And with that, I'm excited to hand things over to Brian.
Well, thank you very much, Patrick, and thank you everybody for joining us today for our presentation on reducing total cost of care through innovations in medication risk reduction. As Patrick said, you can send questions through the chat, and I will address questions at the end of the presentation. Also, at the end of the presentation, you'll find my email address if you have questions after the fact and wish to contact us. Also, the slide presentation will be available upon request by just contacting me through that email. Again, my name is Brian Peltz. I'm a pharmacist, and I'm the Area Vice President for Business Development at Tabula Rasa. Prior to joining Tabula Rasa, I was the Chief Pharmacy Officer for a startup PBM and Managing Principal for Medicaid and Marketplace lines of business for a national PBM, where I engaged Tabula Rasa for its unique approach to medication safety and improving patient outcomes. I also have deep experience as a pharmacy executive for several health plans in the Medicaid and Medicare spaces. Our objectives for today are to understand how health plans can use advanced medication safety science and to identify and intervene with patients at risk for adverse drug events. We'll also look and recognize how the MedWise tool uncovers hidden risks associated with adverse drug events. And we'll describe how new personalized approach to improve member outcome and achieve cost savings in MTM and Medicaid programs. Polypharmacy is rampant. The Lone Institute published a paper in 2019 that highlighted the increasing prevalence of polypharmacy. From 1994 to 2014, there was a 300% increase in the number of patients taking 5 or more medications at a time. So 14% in 1994, increasing to 42% in 2014. The ability to identify multi-drug interactions becomes very difficult as regimens get more complex. The reasons for this growth has been attributed to direct-to-consumer advertising and the patient's expectation to receive a prescription when they visit their provider. It also comes from the lack of having a quarterback overseeing all of the patient's healthcare experience. Patients see multiple providers, often receive medications from different pharmacies like retail, specialty, and mail, and sometimes use their prescription benefit, and sometimes they pay cash. And they consume multiple over-the-counter products, including nutraceuticals and dietary supplements. These factors make it very difficult to identify potentially life-threatening drug-related events using traditional tools. Let's take a moment now to also define an adverse drug event and define some basic terminology relative to the harms caused by drugs. An adverse drug event has been defined by the Institute of Medicine as an injury resulting from medical intervention related to a drug. This broad term encompasses both medication errors and adverse drug reactions. A medication error is a result of inappropriate use of a drug that may or may not result in harm. The key word here is inappropriate. Someone made a mistake, automated processes didn't work to catch it, or the patient received the interacting drugs from different sources. In contrast, an adverse drug event occurs when a medication is taken appropriately as prescribed at a normal dose for an approved condition, and yet the patient is harmed. A large number of adverse drug events are predictable and preventable. With the help of technology, a pharmacist catches major contraindications with concomitant therapy. With basic education provided in pharmacy school, residency training, and with training received during clinical experiences, pharmacists are also able to optimize the timing of and administration of certain medications. The Lone Institute report also identifies that increased numbers of adverse drug events are directly correlated to the increased hospitalization and emergency department visits. Year over year since 1985, studies indicate that for every dollar we spend on medications, we spend at least another dollar for the problems that medications cause. These costs include ER visits and hospitalization. What we see is that the more drugs a patient takes, the higher the risk for an adverse drug event. If a patient is taking 2 or more medications, there's a 13% risk for an adverse drug event. If the patient is taking 7 or more drugs, that risk increases to an 82% risk for an adverse drug event. Adverse drug events were the 3rd leading cause of death in 2019, and today, only because of COVID, adverse drug events are now the 4th leading cause of death behind heart disease and cancer and COVID. These drug events result in over 1.3 million emergency room visits, costing about $1.62 billion annually, over 2 million hospital stays, and more than 3.5 million physician office visits annually in the outpatient setting. This slide is just another illustration of the increasing number of medication-associated adverse events. There has been a 45% increase since 1995 in the number of people with chronic medical conditions. We need to be laser focused on the drugs that these individuals are taking that are effective and that care is coordinated. Attention needs to be paid to avoid prescribing cascades. That is, prescribing another drug to treat the side effects of another. In mental health issues, pharmacogenetics can affect how a patient metabolizes their medications. Our system can help them pick the most effective drug sooner. And as we see from this slide, 59% of emergency room visits from adverse drug events are associated with anticoagulants, diabetes agents, and opioid analgesics. The challenge that we have is traditional programs have missed opportunities. Traditional programs are generally focused on the number of medications that a patient takes, or they can be focused on the number of chronic conditions. And even when we interact with those two, there are a number of missed opportunities. These are the medications that we focus on, as well as all of the others, to identify the risk that the patient may have. Disease management programs traditionally have been siloed under that, and the future is that we should be looking at all the medications a patient takes so that we don't miss those opportunities. One size does not fit all. I've talked about the why and the who, and next I'll shift gears to the how. Drug-drug interactions are one of the major contributors to adverse drug events. It's historically been very difficult to predict or get ahead of the drug-drug interaction problem because of the one-to-one methodology in our current electronic health records and dispensing systems, as well as the fact that the methods used to detect drug-drug interactions rely on accumulation of sufficient data after a drug comes to market. MedWise helps to fill this gap. It allows a clinician to make a holistic, comprehensive approach to evaluation of a drug regimen based on pharmacogenomics, pharmacokinetics, and pharmacodynamics. We want to make sure that we get the right combination of drugs to the right patient in the right order and at the right time. Next, we'll take a few moments to review pharmacokinetics, or what the human body does to the drugs. There are 4 components to pharmacokinetics. Drug absorption occurs as a drug moves from the site of administration to the systemic circulation. As patients age, some of the key problems with absorption occur based on based on their age, may occur like delayed gastric emptying, which can lead to adverse events. Sorry about that. Distribution is the process by which drugs move from the systemic circulation to the various tissues and organs within the body. Geriatric patients generally have reduced muscle mass, which can decrease the extent of drug protein binding, leading to adverse events. The third is metabolism. Metabolism is a process of which a drug is converted from its original chemical structure into other forms to facilitate elimination from the body. The CYP450 enzymes, located mainly in the liver and intestines, metabolize a majority of the drugs. CYP450 metabolism is reduced with aging. Lastly, excretion is the irreversible removal of drugs from the body. Glomerular filtration rate decreases as a patient ages, which leads to drug accumulation and adverse events if medications are not dosed properly. The next principle that's taken into consideration is pharmacodynamics, or studying the effects that the drug will have on the body. Pharmacodynamics can identify a wanted therapeutic effect of a drug or an unwanted side effect or adverse impact. The drug's pharmacodynamic properties may be affected by physiologic changes of a patient due to a disorder or disease state, aging, and other drugs within the patient's regimen. For example, as patients age, their baroreceptor reflex is slower, which may lead to increased risk of orthostatic hypotension when taking a medication such as a diuretic. This then results in dizziness, chance for a fall, and potentially a fracture. In general, pharmacodynamic effects with medications tend to be cumulative and enhanced in patient populations. As I mentioned previously, it's become more and more difficult with time for a pharmacist to evaluate important drug-drug interactions that lead to adverse drug events. More medications have come to market, and our patients are taking more medications. This is really a recipe for disaster, and that's because the current industry standard of drug-drug interactions compares one drug to one drug at a time. The software then provides feedback on all the different interactions with differing levels of severity. And the pharmacist must search through and determine which interactions, if any, should be addressed. In that patient that's taking 10 different medications, there could be more than 50 drug-drug interactions to assess. It's difficult within this platform to assess the aggregated drug event risk for a patient's unique medication regimen. That's why we at TRHC have developed MedWise. MedWise is a novel software that assesses the combined risk of a patient's medication in aggregate. A pharmacist is then able to look at everything at once to determine the most clinically significant drug interactions. This hub and spoke methodology allows us to look at all of the drugs that a patient is taking together. We call this a simultaneous multi-drug analysis that makes MedWise unique. Through the use of this technology, we provide personalized medication decision support. MedWise is a science focused on 5 elements of risk. The first is the adverse event risk, or relative odds ratio of an adverse event occurring based on the FDA adverse event reporting system. We gather the data from that system, compare it to the patient's unique regimen of medication, and then we're able to assess the likelihood of medication adverse events based on reported events. The second component that we look at when generating our risk analysis and risk score is the aggregated anticholinergic burden. This represents the total anticholinergic burden from a patient's regimen. Anticholinergic burden is associated with GI dryness as well as brain dryness and can lead to significant cognitive impairment. This is ranked on a scale of 0 to 3 for each medication. When we look at the diagram on the right, we see the components of anticholinergic burden. A good example of that is, when you have a runny nose or you have seasonal allergies, you may take Benadryl. Benadryl has high anticholinergic burden because it dries out your sinuses. But at the same time, it's also drying out other tissues and organs of your body, like your intestines and the brain, which can lead to severe cognitive impairment and brain atrophy. The third area that we're looking at in our risk assessment is aggregated sedative burden. Many drugs have a sedative side effect, which can be expected. Sedation can interfere with quality of life, ability to complete activities of daily living, and creates the opportunity for a fall risk. We also rate this aggregated sedative burden on a scale of 0 to 3. This is a good place to look at timing of medication. Our tool allows us to do that. So just like you wouldn't give a patient a diuretic or a water pill at bedtime because it would keep them up all night going to the bathroom, we can also look at what medications causing sedation that the patient needs and avoid giving those at times when they need to be awake. Many patients complain of just being sleepy all day and they feel bad because they cannot complete the activities that they want. And it could be attributed to a medication that's just being taken at the wrong time of day. A fourth component that is very important that we look at is called long QT syndrome. When you look at the EKG of a heart rhythm, we find that some drugs lead to the prolongation of the QT segment. These can lead to unexpected cardiac events, cardiac arrest, or even death. We know that the risk is higher in women, and that when we start to layer multiple drugs with QT syndrome associated with them, that we increase the risk of that event happening. And the fifth and probably most common event that we're looking at is competitive inhibition. This is probably our primary cause of adverse events in many cases. And as we move forward in the presentation, we'll dig a little deeper into that. But we know that the body has the ability to metabolize drugs in different areas. And it also has a limitation to how many and how much of the drug can be metabolized at one time. And those drugs will compete with each other based on their properties for the spaces to do that, which may lead to drug levels being built up, or drugs that need to be converted into a more active metabolite missing that opportunity. This is a good place to give a high-level overview of the suite of solutions that I'm talking about. We talk about our MedWise risk score, MedWise risk reduction strategy. It's really a combination of solutions, a whole suite of solutions that we've put together that, when packaged together, are designed to give a complete end-to-end comprehensive experience to improve patient outcome and reduce the overall cost of care. Our process starts by looking at a population and stratifying it. We use our proprietary software to assess the claims that are provided by the organization so that we can identify those patients most at risk and that should be looked at first. As we've talked about the medication MedWise risk score, that's our assessment. So it's simultaneous, cumulative, multi-drug analysis where we look at all of the patient's medications. Another very important part of that is the medication safety review or intervention. This is where the pharmacist can do medication reconciliation with the patient. This is where they create their recommendations for both the patient and the physician, and a very important part of the process. We have trained pharmacists available to do this. They are the best source of that intervention and knowledge. And the tool is designed to give them the supportive information they need to make good decisions. We also have the ability to bring in pharmacogenomic information that can be imported if it's available. We can use that to be more precise in our recommendations and identify and understand when patients may not metabolize drugs the way we think. If we do not have the information, our system assumes that the patients are normal metabolizers, and then we can layer that in to provide additional support. And then finally, with the ability to have a consumer facing tool, we can also help the consumers manage their medications better as part of the whole process. Let's now, as we talked earlier, dive a little bit deeper into the topic of competitive inhibition. Medications are metabolized primarily through the kidneys and liver, and about 80% of the metabolization occurs through the liver through a system called cytochrome P450 pathways. With our platform, again, simultaneous multi-drug interactions can be predicted. There are usually a limited number of enzyme sites available for metabolism. And if multiple drugs are on board that all require the same enzyme, then they start to compete for who gets attached and metabolized first. Substrates of the P450 system with greater affinities for the P450 enzymes may cause competitive inhibition of metabolism of other substrates with lower affinities. This can result in toxicity or increasing levels of those drugs in the body, or prodrugs not being converted to their more active metabolites. Another way to think about this is that the medications are cars in a parking lot, and the enzymes are the parking spaces. If the cars with the highest affinity are in the parking spaces, then cars are unable to park until that other drug is metabolized and that space opens up. Recently, there was a study published in 2019 that is a longitudinal association of medication risk score with mortality. After adjustments for common multimorbidities and other conditions that increase the risk of death, the study showed that patients with recorded deaths had significantly higher risk scores than others. Higher risk scores correlated with increased mortality. So patients who died had a higher median number of medications, 7 versus 4 in the study. The risk of mortality varied by age and risk score. Highest mortality was observed in patients aged 30 to 49 with risk scores greater than 20. Among that group, a 1-point increase in medication risk score was associated with an 11% increase in the hazards of death. So as we can see from the chart here, that this is a key milestone in the validation of our clinical tool and the utility of the MedWise risk score to indicate clinical outcomes, complementing earlier publications showing correlations between higher risk scores and increased adverse drug events, emergency department visits, and hospitalizations. So a patient with a risk score of 15 to 19, which would be considered high, has a 1.81% risk of mortality. And that goes up to over 2 times if the risk score is 20 or higher. This is another visualization of the risk score and not only how it compares to mortality, but also how it compares with cost. An individual risk score of 15 has a 50% increase in medical spend. With a score of 20, the increase is 100%. That's double the cost of care. Risk scores of 20 or higher at hospital discharge is 5 times more likely to be readmitted to the hospital than with a score of less than 20. A recent study shows that higher risk scores are correlated with premature mortality, as we just spoke about. This is key again as a milestone in the validation of our software. And now to take a look at the tool. This is what MedWise looks like, our patented software solution. This is how our science all comes together. We combined all of these pieces together into the MedWise medication risk reduction tool. It ultimately gives the pharmacist the knowledge they need, to begin creating recommendations toward improving patients' risk. The MedWise risk score is located at the top of the tool. It's clearly visible and is the beginning point of identifying those patients' highest risk. On the left side is our medication risk factors, or the bullseye. The bullseye is the starting point for our clinical review. The closer to the outer edge of the bullseye the factor is, the higher the risk associated with that factor. In this case, the highest risk factor is aggregated anticholinergic burden in the outer red ring, followed by competitive inhibition burden in the darker orange ring. This gives the pharmacist an area to focus their clinical review on the highest risk events. The part of the diagram on the right side, the relative adverse event risks, which we also call the windrows, shows the 10 highest risks associated with the patient's regimen as compared to the FDA adverse event reporting system. Again, we see that our drug abuse, dependence, and withdrawal potential is the area that sticks out on the windrows. Again, both of these tools help the pharmacist focus efforts on the most important risks for each patient. This is our medication risk mitigation matrix. This is packed with information from each drug's bioavailability, renal clearance, aggregated anticholinergic burden, aggregated sedative burden, and components of the cytochrome P450 metabolic pathways associated with that patient's individual regimen. All the patient's medications are listed on the left side of the matrix, and each metabolic enzyme required for that metabolic process are then identified on the right side of the matrix. It's easy to identify where attention should be focused. Without even knowing the drugs, we can see that codeine, metoprolol, paroxetine, and trazodone all require the 2D6 pathway to be metabolized. The colors of the boxes tell us which medications are going to get those parking spaces first. Paroxetine is both a strong substrate as well as an inhibitor, meaning that it is not only taking the parking space first, but it's not leaving the parking lot for a very long time. This can identify that a drug like codeine, indicated with a circle and the percentage in white, is a prodrug and requires metabolism to its active metabolite. If the drug can't be metabolized at this first step, it cannot do what it is supposed to do, which is cause relief of pain. Likewise, under the 3A4 pathway we've seen here, has 6 drugs: codeine, torvastatin, clopidogrel, metoprolol, paroxetine, and trazodone competing for that position. The atorvastatin has the highest affinity for the receptor and actively blocks that metabolic pathway. This is a good example of how changing the time that the medication is given can positively impact the risk score. The tool has the ability to also show administration by time, which is helpful to the pharmacist in determining whether that will be helpful. In most cases, separating competing substrates by 2 to 4 hours of time will reduce or eliminate the competitive inhibition. This would be a good example of having the patient take the atorvastatin at bedtime or after dinner, eliminating competition around the daytime drugs. This also gives the pharmacist a comprehensive look at the patient's overall drug regimen and the risks associated with each drug. A very important topic that has been at the top of the list for a number of years is the risk with opioids. Between 1999 and 2016, number of prescription opioids dispensed nearly quadrupled. There are 630,000 plus drug overdose deaths during that time. This also led to an increase in the rates of emergency room visits, observations, and hospitalizations. 80% of opioid-related overdose deaths are accidental or unintentional, and this is in part due to drug interactions. So our tool, as you can see, is very important in helping to identify those kinds of opioid interactions. And our next slide here is a simple example illustrating that fact. In this case, a patient with inhibition at the 2D6 metabolic enzyme. Metoprolol is a strong substrate, which ties up the enzyme so that hydrocodone, a prodrug, is indicated with the white circle, cannot be metabolized to its active metabolite that actually provides the desired pain relief. The prescriber may increase the dose of the opioid or add another drug to the regimen. The hydrocodone levels continue to increase over time, and the patient has inadequate pain relief. If for some reason the patient's blood pressure is not controlled and the provider decides to change the metoprolol to a different drug, all of a sudden now the drug that's taking up that parking space is gone, and hydrocodone can flood the parking spaces, and which can lead to an overdose situation where there's excessive amount of drug circulating that needs to be converted from prodrug to active drug, and that occurs causing the patient a potentially life-threatening situation. One of the things we also know is that we've studied and understand what the outcomes are when a patient receives a medication safety review and intervention, as opposed to those who do not receive a medication safety review and interaction. Healthcare costs in a patient who has received a medication safety review have shown to have an 8.8% reduction, as opposed to those patients who have not had a medication review showing a 1.8% increase. Hospital admissions have been shown to be decreased by 20%, where with those patients who have not had a medication review have only seen a reduction of 7.4%. We see the same kind of results in hospital days with a 22.2% reduction and an 8.8% reduction in the group that did not receive intervention. Mortality has also been decreased in that those patients receiving an intervention have shown a 2.5% increase in mortality, and those without almost doubled at 4.5%. This graph also illustrates similar outcomes, the same outcomes, showing that MedWise risk scores are directly correlated to increased hospitalizations, increased hospital lengths of stay, and increased total overall medical costs. Our studies have shown that for every point a MedWise risk score is increased equates to an 8.6% increase in the odds of having one or more adverse drug events per year. It also shows an additional medical spend of just over $1,000 for every MedWise point, 3.2 additional emergency room visits per 100, and 2.1 additional hospitalizations per 100 members. All of our data is peer-reviewed and published. We have a scientific research center located in Lake Nona, Florida, that conducts all of the research and looks for gaps in the literature and gaps in the knowledge to study and publish on. To tie back to the beginning of the presentation, where the traditional focus was on identifying based on high cost and high utilization. With the MedWise tools, you could identify by low, medium, and high those members with medication risk, combine them with high cost to identify those members with high risk and high medication risk, and then you could focus your efforts on that population. So you can do your medication risk stratification, your cost stratification, put those together and still focus on a population and help identify those patients that would be most benefited by conducting the risk mitigation process. Much of the science that we use has come out of the CMS's Enhanced Medication Therapy Management Program, which we've taken part of. That began in 2015 with the CMS Innovation Center and an Enhanced MTM program. It was a 5-year program that's just starting to wrap up this year. There were 5 regions, in which Tabula Rasa was part of Region 25. And with our work with Blue Cross Blue Shield of Northern Plains Alliance, it looked at outcomes and aligned incentives. There were over 200,000 patients that were participating. 15% of those patients, or about 35,000, had a high MedWise risk score. And then engagement over time was about 15,000 members the first year, 20,000 the second year, and 24,000 the third year. The outcomes were that MedWise risk stratification for those patients and a potentially $129 million savings due mostly to reductions in emergency room visits and hospitalizations. Another area that we're spending a significant time and effort on right now is also looking at how this technology can support the needs of the Medicaid populations. And the example that we use here is the recently published work that's going on in New Jersey. The EMTM solutions are being used to create an MTM and medication review process in the Medicaid space. And many states are considering similar Medicaid requirements. Many states are beginning to address the issues as pharmacists as providers, while others are directly addressing the medication risk reduction for beneficiaries. When we look at the model that we use to show that this is really turnkey for Medicaid and portable from what we see in the Medicare space, we would receive the pharmacy claims or medication profiles from the plan, perform the simultaneous multi-drug analysis using our MedWise tool, identify those members at highest risk, conduct medication reconciliations, complete the medication safety review process, and then communicate that with the member and the physicians. And then also go back in a period of time and assess and validate that our recommendations were taken and that we did see the reductions that we expected. Next, I'd like to share with you a case study of how we've used the MedWise tool and processes in a Medicaid population. The Medicaid population that we worked with was a managed care organization in Virginia that saw two populations of patients. They were contracted for two populations. The study began in 2018. And Virginia is a state that requires medication therapy management programs for Medicaid. Their requirements are listed. So they require that the program meet or exceed the requirements for Medicare Part D. They're required to have community pharmacy involvement, requires face-to-face or telephonic consultation with a trained pharmacist, and requires annual reports that trend interventions, outcomes, and potential savings. Again, this is the program overview, workflow overview. We're provided with eligibility, pharmacy claims. We run our MedWise software. We can import pharmacogenetic information if it's available. And then we look at targeted interventions. There are over 1,000 clinical algorithms that run daily against the claims. These include things like medication adherence, gaps in care, medication safety. We complete comprehensive medication reviews. And also an important part is the medication safety review, using our science and tailoring recommendations to that patient. We can do this by utilizing call centers and pharmacies. Tabula Rasa has 8 regional contact centers that are staffed by over 800 clinical pharmacists and pharmacy technicians. Many of those are directly associated with a college of pharmacy, so they use pharmacy interns and pharmacists in training in a lot of the capacities. But what's also unique is that we have contracts with community pharmacies across the country. We currently contract with about 18,000 pharmacies. And using our software, we can push those interventions directly to the pharmacy so that the pharmacist can have the intervention with the patient. This is a very important piece of the healthcare delivery system. It's challenging and has been challenging over the past year with the pandemic, and that pharmacists have been very busy with not only COVID testing, but in the late stages with vaccinations. So we have the ability to use community pharmacists who their patients have already built trust and visit on a very frequent basis. And back that up with our call centers. We like to refer to this also as our air and ground support. So we can use community pharmacists as our ground support. And if they're unable to address that patient within a period of time, it can automatically be picked up by our contact center and telephonically done. For a case study, we had these two populations of patients. So the first population in Virginia was called the Commonwealth Coordinated Care. It was only about 15% of the eligible members. And those are dual and dual eligible members with long-term support services, age blind and disabled, or developmental disability waivers. Average age of the population was 51 years old, with 52% being female. Their average RX count was 4.5 prescriptions per month. The dual eligible population was excluded from our study. And the chronic conditions that we looked at were diabetes, dyslipidemia, hypertension, heart failure, osteoporosis, and respiratory disorder. The second population in Virginia was called the medallion population. This is primarily parents and dependent children, pregnant women, special needs populations, and foster care. Their average age was 17 years old, with 62% being female, and they had an average prescription count of 3 per month. Their chronic conditions were bipolar disorder, schizophrenia, depression, diabetes, and hypertension. So starting out with 88,000 plus eligible members, the two population stratifications are there. With the Commonwealth, the CCC Plus group, we looked at 7 chronic meds and 2 or more chronic conditions. And with the other group, 3 chronic meds and or 1 chronic condition, along with high-risk members as identified through the stratification tool. We further looked at prioritization of the population down to those patients having a CYP2D6 drug-drug interaction. From the population, 22,833 members qualified for MTM, which generated 25,038 targeted interventions. We were also able to address HEDIS measures like medication adherence, gaps in care, high-risk medications, drug-drug interactions, and drug condition interactions. When we look at the whole population, the 88,000, this is all the patients together with their risk score. The MedWise risk stratification score can range from 0 to 50. In this population, it went from 0 to 35, with the average risk score being 18.53. In the targeted population for the pilot that we looked at, we prioritized, again, the opioid CYP2D6 drug-drug interaction along with high-risk patients. Their opioid, the average risk score for that group of population was 25.2. Demographics for the population, the median age, 46.5, and mostly female. We also looked at geographic distribution to assure that we had good spread across the state. The total population on the left, you can see, is relatively spread around the state fairly equally, with some red or hot pockets. And then the population that we were able to intervene on the right side. So it validated that we didn't have any geographic pocketing or miss any areas of the state. Here are the results of the medication safety reviews that were completed. Again, we looked at high risk in the opioid CYP2D6 DDI. 172 medication reviews were completed in the high risk population, 32 in the opioid population, for a total of 204. Medication risk count around 14, and the average recommendations were about 3.5 on average. One of the things that we recommend when the pharmacists are doing their risks is that oftentimes you could identify 7, 8 recommendations. We don't want to overwhelm the provider or the patient with too many at one time. So again, the tool is very helpful in identifying those recommendations that would be most prudent initially, and then there can be future follow-ups with that patient to do additional recommendations over time. The chart at the bottom indicates from that population, the dark green was the medallion population, the dark orange would be that CCC plus population. And what is of note here is that these 204 MSRs were completed within a 30-day time frame. So we're able to take a large population, stratify it down to a manageable size, and then actually conduct and complete that medication safety review within a very timely period. This next slide is a summary of the interventions that came out of that population. 85% of those recommendations were encompassing of competitive inhibition, sedative burden, and anticholinergic burden. 3 of the top 5 interventions were prescriber focused and 2 were patient focused. So as you can see from the slide, the number 1 was a recommendation to change, focused at the physician. Number 2 is a recommendation to change medication timing, which would be focused with the patient, take their medication at a different time of day to mitigate that chance of a reaction. The third recommendation to discontinue, which again would be focused at the physician. So 3 of the 5 were provider focused, 2 were patient focused, and we're able to track, trend, and report on all of these outcomes. The exciting part of this is that this is where the rubber hits the road, is that the impact on the average risk score was a reduction of 6.35. That means that opioid DDI population, which had a risk score average of 25.2, was decreased to 18.5. So they went from very high risk factor to just over the high risk factor area. Again, this is direct impact on the total cost of care, which includes not only pharmacy costs, but also medical costs. And as we've spoken, our emergency room visits and hospitalizations. So very exciting. And then based on that $1,000 per reduction in score, potentially resulting in greater than $1 million of savings in 1 year. The last part that I'd like to show you is an individual patient example from that population, and show you how we use the risk mitigation matrix to affect that patient. The patient's name is Judy. She's a 57-year-old female. She was on 12 medications. Her diagnoses included hyperlipidemia, depression, diabetes with complications that included neuropathy, arthritis, and GERD. These 4 medications were identified as causing potential medication events. So the bupropion, duloxetine, ibuprofen, and trazodone. She was taking trazodone 200 milligrams at bedtime. And because of some knee pain that she had, she was taking 800 milligrams of Motrin twice a day. She was a smoker, but the bupropion didn't work and she didn't end up stopping her smoking. But she continued to be on the drug for more than a year after starting it. So if you remember from our previous discussions, the darker the color in the matrix, the more affinity for the substrate. In her case, bupropion is the strongest affinity substrate, blocking the other drugs from metabolism. Her risks were identified. She had a moderate high risk of competitive inhibition and excessive sedation. She complained of having issues with insomnia despite her high sedative burden. She uses high dose ibuprofen to treat arthritic pain in her knees. And Judy was using bupropion to help her quit smoking, but continued for more than a year after failing to quit. And bupropion as a side effect has a high incidence of insomnia. The recommendations that were developed using the tool were that stopping of the bupropion to reduce the risk of competitive inhibition with duloxetine and trazodone through CYP2D6 and to help with her insomnia. She was advised to monitor for excessive sedation. Ibuprofen treatment for the knee may not be necessary. So the recommendation was to stop the ibuprofen and then add diclofenac gel as an option to use for her to use localized treatment on her knees. In this scenario with the recommendations that were made, her risk score was reduced from 23 to 14 with 2 simple recommendations. And this is dramatic changes that we see in risk reduction. Again, because it's very difficult to look at all the patient's meds together, to do that simultaneous multi-drug analysis, understand the metabolic pathways, and then affect very positive changes for patients. Patients feel better when they're not sedated. They feel better when their pain has been relieved. And then the overall risk and costs of additional medical care being needed are reduced. So thank you again for the time that we spent today. We did make it in under an hour. If there are any questions, please add them to the chat. I don't see any questions in the chat at this moment. Again, you can contact me using my email is identified here. Also, if you'd like to receive a copy of the slide presentation, it is available by request. Again, please send me a request for that, and I'll be glad to send it out to you.
Okay, fantastic. Thank you very much, Brian. Okay, Marvin, we got your request. We'll definitely get you the slides. Yes, thank you, Brian. That was a very informative presentation, a very important topic. And as a reminder, all the attendees will receive a link to the presentation on MHPA's YouTube channel. Just Google or go on YouTube, search MHPA. We have a ton of great presentations for you to view, great content. I invite you to do that. This will be included. And, you know, thank you again to MHPA Bronze partner, Tabula Rasa Healthcare. You know, you guys are doing great work with our members. You are helping our Medicaid members live better, healthier lives. We thank you for your support, your expertise. You've been an integral partner throughout the years. And thank you to our attendees for joining us today. And we'll have more Webinar Wednesday topics for you. Be on the lookout for our emails. And again, thank you very much for attending and have a great day.
Thank you.
Thank you, Brian.